Good afternoon, everybody, and welcome to Caraconference 2022. I'm Adam Riley, Prevention Manager at Caracol. And before we get started today, I'm going to go through some slides about housekeeping. So first off, Caracol, we are Greater Cincinnati's HIV service organization devoted to positively changing lives in the fight against HIV through prevention, promoting health and well-being through HIV testing, PrEP access, harm reduction tools, and sexual health education. Housing, offering permanent supportive housing and short-term assistance to prevent homelessness and destabilize people living with HIV. Care, helping people living with HIV access healthcare they need through medical case management and pharmacy services. For more, please visit caracol.org. And to participate in today's session, if you're joining from a laptop or a desktop, your screen should look similar to this. And if you have technical questions or want to introduce yourself or something like that, please use the chat function. But if you have questions for our panelists, please use the Q&A function. We'll be monitoring that and we'll get the questions to panelists or presenters. And if you're joining today from a mobile device, you can still access the chat through clicking on the three dots more button. That will get you to the chat, or you can still access the Q&A through the white Q&A button at the top right of your screen. Thank you to our sponsors. Presenting partner today is Maytech, Midwest AIDS Training and Education Center at the University of Cincinnati, and AETC, AIDS Education and Training Center, with sponsorship by Gilead. We are offering continuing education credits for each session this week. To receive those credits, you must complete an evaluation by 5 p.m. at the end of each day. The link to that evaluation will be placed in the chat later during the session, towards the end of the session. And then you can also access it through your PDF program for the event today. The QR codes will take you to that respective day's evaluation. And if you're requesting CMEs, email Mary Beth Donica at the email listed right here. That email will also be placed in the chat for easy access. And disclaimer, this program is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award totaling $4,198,345, with 0% financed with non-governmental sources. The contents are those of the author and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. AETC resources. These are some resources for some ongoing education around HIV and hepatitis C. All of these links will be placed in the chat as well for easy access. And now on to CME disclosures. Our planning committee and the presenters for today's session do not have any financial disclosures to make. And then this next slide is just about other financial disclosures and disclaimers related to the CME process. And with that, we're going to move on to today's session, Ending the HIV Epidemic, EHE in Action, an assertive, targeted, and low barrier approach, presented and moderated by Claire Scott, LSW, and clinical supervisor with Caracol. And with that, I will turn things over to Claire.
Hello, everyone. It is my pleasure to share with you all this presentation today, as well as our panel discussion. So thank you for being with us here. So to begin the presentation, I'll first do an overview of what the EHE initiative is, and then I'll move into more specifically how we've been able to implement EHE initiative activities here at Caracol. And then we will have a panel discussion with some of our staff who implement EHE activities here in the area. And then finally, we will have some time for you all to ask some questions directed at our panelists. So what is EHE? Some of you may have heard this acronym before. Some of you may have not heard it before, but EHE stands for Ending the HIV Epidemic. And this is an initiative here in the US that was spearheaded by the Department of Health and Human Services in 2019. And the overall goal is to reduce new HIV infections in the US by 75% in 2025, and then 90% in 2023. So the tools and interventions to end the epidemic have long been available, but the funding has been needed to make those tools and interventions more accessible throughout the US. So this funding has and will continue to increase resources for the prevention of HIV as well as the care and treatment of HIV. However, the funding is not widely accessible to all parts of the US. There were priority jurisdictions identified, and those jurisdictions include 48 counties, 7 states, San Juan, Puerto Rico, and Washington, DC. Here is a visual of all of the priority jurisdictions. So you'll note that in the dark blue, these are the counties, as well as San Juan, Puerto Rico, and Washington, DC, that were eligible to receive funding. And then in the light blue, these are the states that were eligible to receive funding. And some of you may be wondering why, or rather, how was it that these priority jurisdictions were identified? And this was based on, at least for the dark blue, this was based on data from 2016 to 2017 that showed that these areas accounted for more than 50% of new HIV diagnoses. And then in the light blue, these are the states that had a large number of new HIV diagnoses in rural areas. So the light blue states had a heavy rural burden of new HIV diagnoses. And then I also want to specifically focus on the state of Ohio, where Caracol is located. So you can see 3 dark blue areas, and those account for 3 counties that have been made eligible to receive funds. So in the southwest corner is Hamilton County. That is where Caracol is located. And then in the center of the state, we have Franklin County. And then in the northeast region is Cuyahoga County. So the EHE initiative has 4 key strategies, also known as the 4 pillars of the EHE initiative. The first one is to diagnose all people with HIV as early as possible. The second pillar is to treat people with HIV rapidly and effectively to reach sustained viral suppression. The third pillar is to prevent new HIV transmissions by using proven interventions, including pre-exposure prophylaxis, also known as PrEP, and syringe service programs, also known as SSPs. And finally, the fourth pillar is respond quickly to potential HIV outbreaks to get needed prevention and treatment services to people who need them. All right, next we'll move into how Caracol has implemented EHE activities. So I want to first begin by saying that Caracol has been very fortunate to receive funding on both the prevention side of EHE and also the care side of EHE. So I'll be speaking about 2 separate programs, and we'll begin with the EHE prevention program. This program addresses pillars, the diagnose pillar and the prevent pillar. And the service area for the funding is in Hamilton County, Ohio. And we have 2 staff that are 2 health educators that provide the direct services to our clients. And our priority populations for this program include MSM, which is also known as men who have sex with men, African American MSM, trans women, African American trans women, people who engage in sex work, people who are living with HIV who are also not in care, and youth. And 3 of the top duties of the program, which is not limited to everything that they do, but this is just in a nutshell what they do in their day-to-day activities. This includes providing HIV testing out in the community. Also, when they do come across folks who are newly diagnosed or who are living with HIV, they do link those individuals to HIV care. And they also provide the community with HIV and sexual health education. So the following are the 4 objectives of the EHE prevention program. So the first is to provide HIV education and HIV stigma reduction. And this is being done through the establishment of an African-American-led community engagement advisory committee, and also by doing community education and training. The second objective is to provide community engagement through recruiting, engaging, and building additional capacity in both our priority populations as well as the provider populations that work with our priority populations. And also providing counseling, testing, and referral for those at risk for HIV to help increase the number of people who are aware of their HIV status. And then the third objective is to pilot an at-home testing program, HIV testing program for those who are at risk of HIV. And again, this is to increase the number of people who are aware of their status. And then finally, the fourth objective is to link individuals to HIV care within 30 days of a new HIV diagnosis. Right, and next we have our EHE care program. So this program specifically works with individuals who are living with HIV. And this program addresses the treat and respond pillars. And similar to the EHE prevention program, the service area for EHE care is Hamilton County, Ohio. However, given in recent years, there has been a cluster of new HIV diagnoses in Butler County, Ohio, which is just north of us in which is just north of Hamilton County, Ohio. And so with exception and special permission, we have been able to provide some services up there as well. And our staff that we currently have for this program include 3 HIV care coordinators that provide that direct linkage to care, as well as case management services to clients. And then we also have 1 peer navigator that provides that social support to our clients. Priority populations include young African-American MSM, transgender individuals, individuals being released from jail or prison, people who inject drugs, as well as pregnant persons who are living with HIV and are at risk. And 3 of the duties that this program carries out include linkage to HIV care, and then retention in HIV care, and finally facilitating social support opportunities. The following are the 3 objectives of the EHE care program. So the first is to further develop and enhance strategies to coordinate services to increase access to care. I'm sure you all can imagine that accessing HIV care can sometimes can sometimes be very difficult for individuals because of various barriers. So we are looking to increase access to care by providing more community-based services. So going out into the community, meeting with folks face-to-face, as well as expanding medical transportation options, and also incorporating more telehealth services to, again, increase access to care. Another objective is to increase the number of individuals living with HIV to have access to social engagement opportunities. Often living with HIV can sometimes cause some loneliness and isolation, so we want to make a concerted effort to provide more social opportunities to those who are impacted. And then finally, as needed, we will facilitate and utilize enhanced routine reports from state and local health departments to aid in any cluster detection and response. All right, and with that, it is my pleasure to go ahead and introduce our panelists who will be participating in this panel discussion today. So I want to start off by introducing our two health educators that work on the EHE prevention team. We have Jamar Jackson, and we also have Ariel Shaw. And then on the EHE care side, two of our HIV care coordinators are joining us. We have India Brandon, and we have Abriana Perry. And I'm going to take a moment to stop sharing my screen. All right, so I will open up with a question more, which is of course directed at both like the care and prevention side of things. So the first part of the question I wanted to ask the panel is, for those who are living with HIV, what would you all say are some of the barriers to them engaging in HIV care?
Yeah, thank you for that question, Claire. I'll be happy to take that one up. And hi everyone. I hope you all are doing well. So there are a lot of barriers to care that we are finding with our clients that we like to combat. So one of those barriers is there's a huge mistrust in the medical system. I think a lot of this also stems from what we all have been experiencing with COVID-19 and just a lot of misinformation out there. There's a lot of people still believing that HIV is a man-made virus and that people are withholding the cure. So what we try to do is we try to support our clients by meeting them where they are, by going to the medical appointments with them. So we just, when clients are first attending their appointments, because a lot of our clients that we get are just now being starting services at UC and other medical centers. So they are very scared, they're very nervous. So what we try to do is we try to attend at least the first medical appointment with them, help them answer any questions that they might have for the doctor and support them in any way that they need to. And we also find that when we do support our clients in that way, they're also more likely to attend appointments. We also find another barrier to care is transportation. So we try to, again, meet our clients where they are. We try to pick them up in the community, whether that is at their home or a safe location where they feel comfortable with meeting us. We try to take them to their appointments as well. We're finding that with using the Medicaid funded transportation, oftentimes the transportation is either very slow, making our clients late to their appointments, or sometimes they just don't show up. Or if the client accidentally puts in the wrong address to the office, they might drop off that client. They have to actually drop off that client at that location. They're not able to change the location, and sometimes the clients have to walk several blocks to get to their appointments. So we like to try to, again, meet them where they are by providing either Uber health rides, or we try to actually drive our clients to our appointments. We also provide daily passes if they would much rather use the bus system. We provide daily passes for clients to go to their mental health appointments as well. And we also provide monthly passes if they need that support as well. So another barrier is that just HIV stigma. So we try to reduce HIV stigma by providing the service within a service and trying to incorporate more of a holistic approach to care. So whether that is dealing with the homelessness issue if for the client or dealing with any food securities, those are two barriers that we are often seeing with our clients. We try to give them as many referrals as possible, community referrals, as well as utilize any supports that we have around us. So again, we want to provide that service within a service and not just necessarily treating just HIV and talking about medication management, which is very important in our role, but we also, again, want to provide that holistic approach. We also, again, want to try to reduce any HIV stigmas. We want to focus on all the barriers by using any clinically appropriate intervention services. And we like to create goals with our clients and collaborate with them to get them back engaged in care. Thank you, Claire.
Thanks, India. I'll allow some space as well for any of the other staff to share any barriers maybe that they've recognized that their clients have encountered.
I guess I would just speak a little bit more on some of the barriers that India was already speaking about, and that is getting clients to their appointment. And so that first engagement is honestly really one of our most difficult, and that's simply because, as all the points India was mentioning, these clients are used to having all of these barriers against them, that it's kind of different for them to be working with, these supports and everything. And so we might set up, hey, we're doing a meetup, and maybe it takes a little bit more time. Maybe that means we need to try one more time, whatever it may be, like really just focusing on meeting the clients where they're at. And so I just think India did a great job of expressing that, but I just wanted to speak on that more, that's definitely prevalent within the majority of our clients, even whether or not they're housed, I feel like, because it just depends on their comfort level, not only within the medical system, but also, are they comfortable catching that ride? Are they comfortable doing whatever it may be? And are they ready to do that? And so really just focusing on where's their readiness for change.
Right. Any other thoughts before moving on to the next question? I'll just give you all a moment just in case. Right. So the next question, more so I am interested in a little bit more, or learning more about our at-home HIV testing program, which is really exciting. So would one of you please describe how the at-home HIV testing program has been implemented, and why was it implemented? Why was there a need in the community for at-home HIV testing?
Yeah, thank you so much, Claire, for that question. That's actually really good. And pretty much with our at-home testing program, it is fairly new to Caraco. It was actually piloted last year in September of 2021. So since then, we've been able to get those out to the community, also to service our clients better. And we prioritize who we are giving our at-home test to, just based off of the populations that the EHE grant is serving. So mainly our at-home test, we're looking for the population group of MSMs, men who have sex with men, predominantly African-American MSMs, also trans women, African-American trans women, and just people who are involved in sex work. We feel like it was very important to implement this program through Caraco because with the growing the growing outreach that we're doing in the community with Caraco, we do realize that a lot of people with the way we do testing with our mobile unit and our van and everything, that's not typically the best approach in certain neighborhoods to access the people we're trying to access. So also with the reduction of HIV stigma, with the at-home tests, we are able to get those discreetly to people in the community. So that way they're able to test themselves in the comfort of their own homes. And that way we just do a little follow-up with them for reporting and also to get some type of just feedback of how the test went for them, if they have any questions or just any concerns about anything. So the at-home test also brings up a lot of talking points with our clients in the community because it makes them very interested in knowing how the process works. And the biggest thing that we do get from that is the fact that we're able to provide them with counseling even outside of face-to-face counseling. So it gives them a chance to also, reach out to us by email, by phone, or anything like that, just to make their experience a little bit more personal to them, opposed to just, having them out in the open in the community and everything like that. And then also with our at-home testing program, we are going to implement soon a portal online on our Caraco website that people are able to order at-home tests from us and we ship it to them. So that makes it a lot easier for people who may live in like rural communities that does not live in the inner city, and it's not accessible easily for them to get tested. And also it just helps with people who just don't feel comfortable, coming in to do HIV testing, whether it's to pick it up in person or even to do it in person. It still just gives them that option to be able to be tested, to know their status, to get the test for free, and to also just get that personal one-on-one follow-up to make sure that, everything is done correctly. They're getting out any type of concerns or questions that they may have, and also just to provide that support, whether if a person is negative or positive, we're able to refer them to PrEP services if they are negative, if they choose to get on PrEP. And even on the other end of the spectrum, if someone turns out to be positive, we're able to directly link them to care, just with the support and the follow-up that we do have with at-home testing. So that does make that, in my opinion, a really good added testing idea for people who may have run into some of those barriers and who, may need a little bit more education to just decrease the stigma of HIV testing within itself. So I do think that our HIV at-home testing is going along well. We are actually in the process of partnering with some community organizations, and our first one being Women Helping Women, to actually get those distributed in a third party, from a third party. So that way people who may, for some reason, not familiar with Caraco or don't know exactly how to go about getting a at-home test done, or maybe haven't even thought of it, but they visit like those outside organizations very regularly. It's another way to get those tests out, and also to just kind of combat the stigma against HIV testing, working with these other partnerships to just get everyone's sexual health where it should be, and just knock down all of these barriers to people to access HIV testing and support that they need for any type of result that comes from it. So
Thanks, Jamar. I do have a follow-up question that came to me through direct message. So this question is asking, how is the follow-up going with clients after they've received the at-home test, they've maybe completed it or haven't completed it? So first, how is that going? And has there been any linkage to other services because of them being connected through the at-home test?
yeah, so the follow-up actually goes really well. We definitely like to let the client know that within a week of them receiving the at-home test from us, we give them the option to reach out to us first, just, to not kind of put that pressure on the client. But we also do let them know as well, and we do get their consent, that, we will also follow up with you within that week's time, just to get the information, if the test has been taken or not, or just to simply let them know, like, hey, we're here, like we're here to help you. And we want to make sure that you have that support, because, taking a test like that isn't the most easiest thing in the world. So that follow-up is very important because it also gives us a good rapport with that client, to let them know that we are very interested in helping them either way. And with the follow-up, it's actually been going really well. Majority of our clients do let us know any result that they have come from it. And speaking of that, to answer the next question, yes, we've actually had a positive on one of our at-home tests, and it led to that client being directly linked to care with our infectious disease clinic here at University of Cincinnati Medical Center. And they are currently still in care. They are currently now undetectable. And just with that follow-up alone with that client, and even still to this day, just checking in on them, making sure everything's going well and things like that, it has been very beneficial. And even on the flip side of that, we've had a couple people who tested negative on our at-home test, that were able to be referred to be on, through our POPPY program, to be on PrEP, to help them stay negative, and just to kind of just to have that conversation with them after their follow-up, just to kind of get them to realize, some of their sexual practices and what we can do to keep them safe, and, just to have them stay healthy. They were educated on PrEP and just thought it was such a great idea. And just from those tests alone, we were able to get them linked to services like that as well. So yeah, the at-home testing is going really well. And the follow-up procedure from it definitely helps us with our data, but it also helps with the support that the client may need for any result that they get from it.
Great, thank you, Jawan. Great, I'll move on to the next question. So in response to the cluster of new HIV diagnoses up in Butler County, what are some ways that you all have been able to increase case management support in order to link individuals to HIV care?
Yeah, absolutely, Claire. So I can go ahead and tackle this question, and I'm happy to do so. So I just want to start by sharing a couple of the key areas, and then I'll kind of just go on from there. So the first way that I'd like to respond about that question is that within Butler County, 2 of the case managers from our EHE care side of things, so myself as well as one of our other case managers, we've actually been attending a syringe service program, otherwise known as an SSP, within Middletown every week. And then one case manager's been attending, oh, sorry, I got mistaken a little bit. And then I'm over at the outreach site in Hamilton, Ohio, which is still within Butler County. I know that's kind of confusing. But anyways, we've got both of us out there and we've been able to do outreach, and most of the folks that are at those sites are unhoused. So they are homeless, and not all of them are living with HIV. However, we do have a few number of folks at both sites that do attend, and they attend those locations for a couple of different reasons. And then we also in turn have a couple of reasons that we're there. So obviously our goal is to make those connections, to build that rapport, and to get those clients into care as quickly as possible, but also to retain them in care. And so I think that it's really important to note that, because it might be one thing just to get a client, you know, like agreed on board. Hey, I'm going to do this appointment. We're going to do all these things. We're going to go. And then maybe we actually don't hear from them when we go to our scheduled meetup. But by attending each time, I'm building more and more rapport. The other case manager is building more and more rapport. And so they might start by telling me their goals, or they might start by not really wanting to share things with me at first. And that's okay, because I show up, the other case manager shows up, we're there, they know what services are there at the SSP. You know, folks are going there because they're going to get their syringes. It's a safe syringe program. And so it's a really great way of, they're already going there. They're already aware of Caracal, because our prevention team has done a really excellent job of making our name known in that community and making our name known on providing prevention resources. And I think it's still important to mention the prevention resources, just because that's some of the reasons that these clients are showing up. And so at Butler County and Hamilton, where I go, I've got clients that, you know, they're coming up and they're trying to get those condoms, those rubbers, those lube, the Narcan, maybe just toiletries. You know, we've got a great prevention team who brings candy or water or outreach materials, whatever it may be, and it engages folks and it gets them in the door. You know, we're outside, but in the door. And that's a great way of then, hey, I see you're here again. How's it going? You know, what do we have going on? How are we feeling? Are we looking towards getting that appointment in? Like, what are we thinking? And so that's kind of how those conversations initially go for myself, at least when I'm out there. And we have had some success with that. And we've also have another location called New Life Mission. And New Life Mission is a partnership that we've been able to form within Butler County. It's still within Hamilton. And they provide a space that is private for where a case manager can meet privately with people. And so by doing East Avenue, which is in Hamilton, by providing outreach at that area, and then the next day, you know, twice, 3 times a week going to New Life, I can say, hey folks, I'm going to be at New Life tomorrow. If you want to discuss this in a private space, let's do that. Let's make that happen. They provide lunch there. A lot of the folks already know about New Life Mission. And so we're still working on like what's the best case scenario on trying to get folks more engaged in going to that space, but it's there and it's a resource and it's really valuable. And so we're happy to have formed that partnership and move on from there. And so then another way that I just want to address the question is that by meeting with these individuals at these sites, like I mentioned, a lot of these folks are unhoused, meaning a lot of them are living outdoors. So they typically don't have a working cell phone. But because of our program and the resources we have access to, we do have access to a program that will allow us to get clients' phones. And so perhaps they're on Medicaid, they're already approved then, everything like that. And we can get them a phone, we can get them that resource. And we finally just had a success story actually over at New Life of getting that client that phone. Like it was, you know, one that it kind of was a long haul, but we got there. And now we can make that connection towards getting them into an appointment at UC or whatever provider they choose. And so, yeah, so that's a really exciting thing. But it's also, you know, there's more barriers because these folks are on the streets. And so this is often one of the only ways that we can get them into care is by being there, by showing up, by being in that community and saying, hi, I usually go by Abby. Hi, my name's Abby. I'm here. What can I do for you? And even just listening, just sitting, listening, allowing them the space to speak to me allows that rapport to be built. And then a lot of times these clients are, you know, they're more likely to engage. They're more likely to schedule that meetup for that appointment, whatever it may be. So let me just make sure I'm addressing the question all the way. So yeah, so for overall, we've got lots of great ways that we've been able to engage with folks. Sure, there's barriers. Sure, there's, you know, issues. We're still trying to get all of it up and running. What's the best case? But at the same time, we're making that rapport. We're making those connections. And I think at least that our clients, they've expressed to me, I appreciate you being here, or wow, you're actually listening, or oh, you're able to get me this resource, whatever it may be. That's great. And I can try to link them to other resources. It's a little bit different up in Butler County just because we have more limited options on what we're able to do. But there still are a lot of great options, and in trying to collaborate with our prevention team and our Caracal team working in Hamilton County as well.
Thank you, Abby. All right, another question that I have for the panel is how have you all been seeking feedback from the community to help shape ending the HIV epidemic, prevention efforts in particular? So if one of you all could answer that, that'd be great.
Hi, Claire. Thank you so much for that question. I can go ahead and take it. So one way that we have been making sure to get feedback from the community is through a advisory committee. And essentially what this is it is a group of community leaders from Cincinnati within the target demographics that we are trying to reach. And essentially what happens here is we come together about every other month to meet in the evening to kind of discuss ways in which we as the EHE team can help bring care to communities who have been historically ignored. Because one of the things about this grant and about EHE is that we don't have all the answers. And if we want to be intentional about this work, then we have to go right to that source, which is the community. And so some of the feedback that we've gotten in terms of places to test has been them kind of offering up, oh, have you considered Westwood? Oh, have you considered Lincoln Heights? Have you considered Walnut Hills, right? What does the process for testing look like? And one of the most recent things that we've done is we've reached out to advisory committee members regarding our marketing efforts and wanting to make sure that we get feedback on marketing and wanting to know what does it look like for us to create not only appropriate marketing, but inclusive marketing that says you belong here, that says this is your space as much as it is our space. And not only that, but going back to that piece about being intentional, I think that is really, really important in efforts like this, because I do think that there is a bit of a disservice when you don't have that feedback. And I think that through these meetings, we are able to almost provide a place at the table for those who have been historically pushed away.
Awesome. Thank you, Ariel.
Thank you.
I do have a follow-up question to more specifically about the advisory group. So I heard that the planning and the development of it was very intentional. Have there been any surprising benefits that have come out of having this advisory committee?
Yes. And I think that one of the surprising benefits for this has been being able to kind of bridge the gap between direct service, right, and marginalized communities, and basically kind of, again, providing a place at the table for communities who historically have not had access to that. And I think not only that, but I think that one of the other surprising benefits is the fact that this is a learning moment, not just for advisory committee members, but also for us, particularly because, when something arises, right, when we have something that we think might work, and the committee members may say, oh, I don't know about that, right? Then we're able to go back to the drawing board and figure out, okay, where do we go from here? And so I think that this advisory group really helps us to stay on track with what our mission is, and really hold us accountable for the things that we are trying to implement and develop.
Thank you, Ariel. I will allow a little bit more space just in case anybody else wanted to hop in, share anything else. So I'll move into the last question that I have for the panel. And really, I'm just curious about, well, let me first say that we talked a lot about, EHE care separately and EHE prevention separately, and how those, two sides have had to come together, both at Caracol and on the national level, to help end the HIV epidemic. But I'm kind of, curious about your guys' specific experience on some ways that you all have collaborated with one another. So would you all please speak into how EHE prevention, EHE care, or just prevention and care in general has collaborated with one another in order to serve clients better?
Yeah, so that's actually a really good question as well. One of the main ways that we have worked together in this effort is with the prevention staff. We are typically the first people to diagnose someone with HIV. And so once we go through the initial diagnosis, the initial support, and just, kind of working with the client on their own time, but just also letting them know what options are available and what the next steps are. We work very closely at that point with the EHE care team because we are able to directly link clients who are newly diagnosed HIV positive, and also clients who have fallen out of care and they come back in to get tested again, just to have that verification and to get back into care. We're able to directly link them with the EHE care side case management. So with that, it basically puts the client's needs directly first, because it puts them with a paired case manager, but it also helps build a great relationship to possibly keep that client in care, because once we do the initial and prevention, once we do the initial interaction, we kind of keep in contact with that client. And once we've built up a good rapport with them, it's a lot easier for them to be passed off to someone in the case management side of the care team, because if we're recommending them, this is the perfect person that can work with you on this, it kind of makes the rest of the process easier. So it's very important for the prevention side and the care side to be closely knitted with one another, only because it just helps with the client's point of view. If they see how close we are and how much we care about getting them into some type of care, or just making sure that they have that support there with them, especially with the new diagnosis. It makes them feel a lot more comfortable to go on this journey, and for them to know that they're not alone, essentially. So yeah, that's one of the, in my opinion, one of the main benefits of having the prevention and the care side working together.
Thank you for that answer. Just to piggyback off of what Jamar said, he said it excellent. I just want to add that we also try to be present, like Abby said, in the community with prevention. So whether that's going to SSP events, we also have collaborated. Me and Jamar also went out to like different club events, different social events out in the community as well. So just like Jamar said, in case someone does feel like getting tested and they do perhaps do test positive, or maybe they have not engaged in services in a while, you have that case manager readily available to get them back in care and get them enrolled in services or see what we need to do. So I do think that it has been working very effectively in that collaborative approach with everything. Like Jamar said, we work hand in hand out in the community as much as possible. And again, they send those referrals on our way, and we assist in getting those clients engaged in care as soon as possible. And I think that's all I had. If anybody else wants to join in.
Great, thank you. So that wraps up the questions that I had for the panel, but I do want to allow some time for audience members to ask some questions to the panel as well. And you all can do that by putting in questions in the Q&A section. So we already have, oops, excuse me, I slipped off my chair. We already have a few questions in the Q&A, so I'm just going to go through them and ask in order of how they were or when they were asked. So the first question to the panel is, let's see, it looks like a two-parter. Any plans to provide increased education and utilization of injectable ART and PrEP? I'd love to explore those tools and wonder what others may be doing.
Yeah, so we have, especially in the prevention department, we have been to multiple quote unquote work dinners. We have done multiple presentations, or sat through multiple presentations on the injectables. And we have already started implementing that education with our clients. So with that, it pretty much is just a conversation about, like, you know, PrEP and ART medication. But we also have included the information that we've learned about the injectables, and just kind of like, you know, give those as an option for clients to use, especially like highlighting the benefits of them. In some cases, a lot of people aren't too privy on taking pills every day, like medication. So with the injectables, it's like with the PrEP, it's a initial injection is a monthly injection, and then once that monthly injection occurs, it turns into like a 2-month injection that they have to get bi-monthly. So we just kind of like to use the kind of highlight the benefits possibly of injectables, so that way it kind of gives them another option of treatment that they may want to explore. So we have definitely started implementing education and everything around the injectable PrEP, and also the injectable ART medication for negative and positive clients.
Thanks, Shamar. And I do want to apologize. When I did ask that question, I forgot to expand on the acronym ART, which for those of you who may not know, ART stands for antiretroviral therapy and is just another acronym for a medication regimen for those living with HIV. The next one is a comment. So Christy Lee has said that this is amazing, being able to recognize the barriers of individuals who reside outside of city limits. Definitely important to speak into that. And then the next question comes from Julie. Sorry, it just went away. I love the idea of HIV self-testing. How do you follow up with these folks? When I've seen test kits given out, they don't collect contact information. So what is your method? Ask for a phone number? Also, do you collect demographics such as sexual orientation, gender identity, etc.?
Yeah, thanks for that question, Julie. So yes, our follow-up procedure is very low barrier as far and with the risk factors as well. We pretty much don't really have like a major protocol for anyone to receive at-home test. It's pretty much open to anyone that has had sex before to receive one. We just think that follow-up is important though, because we also have noticed that with a lot of places, especially with ohiv.org, where you can already get an at-home test, there's no follow-up being done. And it kind of just leaves a client, just out there just wondering like, hey, what do I do next? Like, I don't know where to go or anything like that. So with contact, we do ask the client if they would prefer to leave a phone number or if they would prefer to leave an email. Those are the typical two ways that we are able to do follow-up with the client. And also with that, I spoke on it before, but again, we do get, excuse me, we do get their consent to reach out to them if we don't hear from them first. So with that, it just also puts that extra layer of, we're really here to try to help. We're going as far as to get a consent from you to be able to contact you just to get some type of answer. And with our risk factors, again, we're focusing mostly on the populations that we're trying to reach. So again, that is the MSM community, the African American community of MSM, and also trans women themselves, and also sex workers. So even if you don't really follow into any of those categories, you can still receive a test. But we just also really make sure that we try to collect as much information as possible without it being too like detailed or like too strenuous, because we just want to make sure that these are available and accessible to pretty much anyone that feel like they need to be tested. So we don't want to have to turn someone away because they may not do sex work, or they haven't had sex with other men or something like that. So we do collect that. And then with the demographic information, we really want to just get, a sense of who the person is. So we get their name, their birth date, their gender. And we don't necessarily ask their sexual orientation, but that information kind of presents itself once they answer the risk factor question. So again, we just try to make the information as low barrier as possible to make these easily accessible for anyone who needs one.
Thanks, Jamar. Another question we have is, are clients able to keep these, and by these I think the person means the at-home HIV test, in order to show proof of being negative? Do they know if these ever overdevelop? And by overdevelop, it means like showing a thin line that may cause the client to think that they might be positive. The person also noted that this can happen with pregnancy tests, so wanted to know if the same thing could happen with at-home tests. So sorry, that was kind of jumbled. I guess the first question should really be, are clients able to keep the physical at-home test to show that they're negative, or are they able to get something else that shows that they're negative?
Yeah. So once the client is given the test from us, I mean, technically they're able to do whatever they want to do with it. So if they keep the actual test itself for a negative result, they are able to do so. The test itself is in a kit, so it comes with, you know, like the directions of how to use it. It kind of reminds me of like how you use the example of a pregnancy test or like the COVID-19 at home test. It's pretty much that same way. Or if they choose, they also do have the option to, you know, meet us out in the community per se, or come into the office to just show proof of their identity to get a negative letter or a negative card that we have at Caraco, just to show that as well. So they do have options to show their negative status, but they are also able to keep the test themselves too if they would like to.
Thank you. And do you all happen to know with the at-home HIV test, kind of similar to like the COVID at-home test or like the pregnancy test, is there ever a chance that like if after a certain time frame they're technically like overdeveloped and that they're not accurate any longer? Do you all happen to know that?
So I know they do last for a little while. So like even if someone gets it and they don't take it within a week, this test itself is still able to be used, I believe up to 6 months. However, we have not had any complaints or like comments from any clients that receive them of the test, being inaccurate or anything like that. The only thing that we do just let them know that when they do take the test, it has to be read 20 to 40 minutes after you've administered it to yourself. The test itself unopened lasts a while, but once the test has actually been used and processed, it has to be read within 20 to 40 minutes of the initial oral test for it to have been read.
Great, thank you. And it looks like the last question, unless anybody else from the audience wanted to put in another question into the Q&A. The last question is, how long will these EHE grants last? Will these terrific staff be funded all the way through phase 1, i.e. through 2025? And I'll actually step in and answer this question more so because it's related to funding. So overall, the US has made a public commitment to funding the EHE initiative. And that has been done both through former President Trump as well as our current president, President Biden, have both made commitments to funding. And then as far as like individual agencies receiving funding, as with most other grants that agencies receive, our programs are continually evaluated to determine like effectiveness as well as like need for funding as well. So say hypothetically, like there was a jurisdiction that was able to make significant improvements in the rates of new HIV diagnoses and HIV transmission. I would imagine that like if by 2028, there wasn't like a visible need for them to receive funding, there could be the possibility that they would either step down in funds or end funding altogether. That's just my assumption. But to say that like with 100% certainty, like certain areas will receive this funding forever, I can't say that with certainty, but just know that it's been a national commitment to provide these funds and to end the epidemic. So I imagine this will continue until 2030 when the epidemic will be ended. All right, I will leave a little bit more space for any other last minute questions or anything like that. Otherwise, we can go ahead and wrap up. All right, well, thank you all. I am going to pass it back to Adam Riley, our host.
Thanks, everybody. So all the information's been put in the chat for the evaluation. Make sure if you're seeking any kind of education credits that you fill that out by 5 p.m. today. I'd like to thank Claire for moderating and presenting, and Jamar, India, Abby, and Ariel for participating today. I think it was a great conversation. So yeah, and tomorrow, just like we have sessions all week, we have another session tomorrow, starts at noon. We will be hearing from 2 people out of the University of Chicago who are implementing Rapid Start ART in a community setting and not in a like clinical setting. So they're doing some pretty interesting work, and hope that you all can join us.